Hello, everybody. Welcome to today's webinar. Great that you are joining. My name is Martina Scheidt. I'm from the WMBA office, and I will be your moderator today for this webinar. We're very happy to present the World Marrow Donor Association and the European Society for Blood and Marrow Transplantation, who have joined forces to update you on all the activity to ensure availability of unrelated donor grafts and CAR T-cell products during this corona pandemic. Should you have any questions during the webinar, you can send them to us in the Q&A, and after the presentations, we will have time to answer them. If we don't have time to answer all your questions, then we will make a written Q&A afterwards, and you will be able to review that on the EBMT website and the WMBA share website. If you have any technical issues, you can address those in the chat, and Dolores and Luisina from the EBMT office will try to offer solutions to you. Today's presentation will also be shared in a PDF form on the EBMT share website, and links to several web pages that will be shared with you in the presentation will be accessible also on our web pages. I would like to give the floor now to Nina Will. She is the chair of the EBMT Donor Outcome Committee, and she will start today's webinar. Welcome, Nina.
Thank you, Martine. So, as already said, this webinar is brought to you jointly by the EBMT and the WMDA, and the topic today is how to ensure unrelated donor grafts and CAR T-cell products during corona pandemic. My name is Nina Worrell. I'm the chair of the EBMT Donor Outcome Committee, and today 5 distinguished speakers will present information and data on this topic, and these are Professor Bronwyn Shaw. She is President-elect of the WMDA and Associate Chief Scientific Director of the CIBMTR, Miriam Fechter, who is the Medical Director of Matthews Foundation and the Medical Consultant of WMDA, Anne O'Leary, she's Assistant Director of Donor and Transplant Service of Anthony Nolan, Gabby Rell, the Director of Medical Business Development of the DKMS, and Professor Christian Chabanot, the Chair of the Cellular Therapy and Immunobiology Working Party of the EBMT. Our learning objectives today are to inform healthcare professionals about the current state of knowledge regarding the COVID-19 pandemic and its impact on the provision of unrelated stem cell transplants as of today, to identify good sources of information in the area of donor care in the COVID-19 pandemic, to relay our current understanding of the impact of COVID-19 on transport and provision of CT samples and stem cell products, to know what you can do as healthcare professionals to get an unrelated transplant in your center or to work on alternative solutions like cord blood grafts or cryopreserved products, and to provide information about what EBMT and WMDA are doing in the COVID-19 crisis. Without any further delay, I would like to hand over to Bronwyn Shaw.
Thank you very much, Nina and Martine, for the introduction. It's a pleasure to talk to everybody here today and hopefully to give everybody an update of where we are and what the WMDA and EBMT have done together to try and harmonize communication and recommendations to the donor community and also to transplant centers. So on this slide are a lot of very helpful links that, as Martine said, you'll be able to access later. The WMDA has a donor suitability committee. This committee is made up of a number of medical directors from different countries around the world and chaired by Hong Yang from Australia. You can look at those recommendations on the WMDA wiki site, and of course today we're focused on coronavirus, which Miriam Fechter will present in coming slides, but there are also suitability criteria for a number of other factors. We'll also talk about the transport of products and how that has been done in collaboration between the different countries around the world. And Gabi Rao in her talk will concentrate some of her slides on this topic. You'll notice that there are a number of webinars that WMDA has done from individual countries explaining what their registries are doing, but also from groups within the WMDA medical group, the emergency task force, and cord blood selection. And all of these are recorded and are available for you to look at. And finally, on this slide, there is a very helpful page on the WMDA website, which is updated on a daily basis and which shows what the individual registries are recommending, as well as a lot of other very helpful advice. And during this presentation, Anne O'Leary from Anthony Nolan and Gabi Rao from DKMS will also touch on some of these important points. So before we move on to the other presentations, I'm just going to show you briefly a few slides with some data that the WMDA and the individual registries have been able to collect to show activity and trends during this time. On this slide, you can see the number of searches which are done through the WMDA Search Match and Connect program. As you can see, the number of donor searches shown in green on the left side are decreasing over time. In fact, 20% fewer searches occurred towards the end of March compared to earlier on in March. But on the flip side, you can see that the cord blood searches have increased a lot during the same time period. We are able to show you some data from a few individual registries. This is from the Italian bone marrow donor registry, and this shows the number of products actually provided in March. What you'll see firstly is that the number of products provided in March, in fact, for 2020 is higher than that for 2019. And in green is those products already provided, and in yellow, those that are shipped and ready to be infused. And of course, that yellow will now be lower as many of these products have been infused. This is an amazing effort from the Italian registry, as you all know, have been facing really big challenges. On the following slide, we have similar data from the DKMS. Again, you see this evidence that March is an incredibly busy month for the registries and much more busy than the previous year. On the next slide, we see data displayed in a slightly different way from the National Marrow Donor Program, Be the Match. This data is shown week by week, and in the blue bars you see donor collections done for domestic transplant centers in the United States, and in the green bars you see that activity for international transplant centers, and you see that that activity is very stable over this period of time. As you saw in that first slide from the WMDA, we are definitely seeing a reduction in this as we go into April. On the next slide, you'll see the cord blood shipments. NMDP, as with the WMDA, has seen an increase in the searches for cord blood, but despite an increase in shipment in the middle of the month of March, we are now seeing some declines in shipments of cord blood. On the next slide, I'm showing results of a small survey that the WMDA performed, asking just a very few questions of the WMDA registries in terms of what their activity looks like at the moment. On the previous slides, you have seen from some of the very large registries what these look like. And in red on this slide, you can see that there are a number of registries listed who showed no cancellations or other issues in their ability to provide donors during the month of March. But of course, on the table, you do see that there are some registries who are experiencing both logistic issues on the registry side, such as the collection center and donor worry or availability, and also on the transplant center side. And this is quite variable through different registries. You will be able to see that on the WMBA share site, but you can see that there are several registries who are having some problems with providing donors and expecting to see a drop-off in the month of April. However, it's really important to make a couple of points. The first is that, as you can see from these previous slides, that the collaboration internationally between societies and between individual registries has really been remarkable to see, and all of the information being accumulated in a single place has been incredibly helpful for the registries, and we thank the WMBA office for keeping that all together. In addition, several of the registries have banded together to put out opinion pieces and promote the use of unrelated donor products. And here's one example with Steve Devine and Alexander Schmidt, who collaborated to produce this publication in the Cancer Letter that was just produced. It's definitely worth reading for all of you if you have an opportunity. And the message is that the unrelated donor registries are open for business, that people are working hard to make sure that we can provide products for all of the transplant centers and patients who require them, and certainly that unrelated donors are still seen as being a very important cell source for all of our patients. On the final slide are some upcoming webinars that we encourage you all to join. And I'll now hand over to Miriam Fechter.
Thank you for the very nice introduction. I'm Miriam Fechter, medical consultant of the WMDA, and these slides were prepared together with Hoon Yang, chair of the Donor Suitability Committee. I will talk about the WMDA position on donor care and suitability during Corona. This is the WMDA position, and we acknowledge that there may be law and regulations locally which are different from the WMDA position, and of course those must take precedence. I will explain to you what our position is. Regarding donor suitability, we feel that we should focus on donor safety, and so far there is no evidence of transmissibility through blood or stem cells. Risk factors as defined for donors to be infected with coronavirus is contact with a COVID-19 patient and recent international travel, especially if via air or by sea, and of course if the community risk of the country of residence of the donor is lower than the country to which the donor has traveled. The deferral period which we recommend when those risk factors are present, if it is feasible, is between 14 and 28 days, which is twice the median or twice the maximum incubation period. Testing for SARS-CoV-2 is recommended if there are any symptoms which are suggestive of COVID-19, and otherwise WMDA does not recommend routine testing. Next slide, please. There is no licensed test for blood or hematopoietic stem cells yet. The new coronavirus has receptors in the nasopharynx, which does not necessarily mean that the virus is present in blood or stem cells. Swabbing all donors for SARS-CoV-2 prior to donation may have some potential value because it may prevent an incubating donor from getting GCSF and from exposing staff to pre-symptomatic COVID-19, and it may provide early warning that the donation will not proceed. However, we do acknowledge that routine testing is hard to justify if community risk is low and or testing capacity is limited. So swabbing all donors for SARS-CoV-2 on the day of donation, especially when they are asymptomatic, has no value, we feel, because it does not prevent harm to the donor because the donor has already donated at the time the result is available, and it does also not prevent harm to the recipient because so far there is no evidence for pre-symptomatic viremia. Next slide, please. Donor care. Of course, we should focus on taking good care of our donors in these times. We should, of course, minimize the risk of exposure to COVID-19. So we should urge donors to follow the government guidelines and rules and persuade them to do even better. Avoid public transport, for instance, and follow strict hygiene measures and social distancing measures, and make sure phlebotomy and collection facilities do the same. Regular screening for symptoms is recommended both to protect the donor and to protect staff at healthcare facilities to be exposed to donors. So we recommend to ask donors for symptoms prior to start of conditioning, prior to and during mobilization, and of course during collection. At a minimum, we recommend to test when the donor is symptomatic and to interrupt or stop mobilization when there is concern for donor safety. Post-donation screening should be for symptoms only, and of course we ask everyone to report adverse events to the WMDA so that we can analyze which measures are best to follow in these times. Quarantine of the product at this point is not recommended by WMBA, and in the next two slides I will explain why. Routine cryopreservation is not the same as quarantine. It is generally allowed and even recommended, as already pointed out by Bronwyn, because it allows the patient conditioning to start only after the product had safely arrived to the transplant center. And of course, this makes that there is a delay between donation and transplantation, but it is not the same as a quarantine period. Quarantining the product means that you do not infuse the product and do not start conditioning of the patient for a certain amount of time, for example, 14 days. And in this time, the donor should remain symptom-free or test negative for SARS-CoV-2, and only then the product is allowed to be infused. Next slide, please. Why do we not recommend this? Because the donation could very well have preceded the infection, and if the donor develops symptoms of COVID-19 after donating, then the donation was collected during the pre-symptomatic period, and there is evidence of respiratory infectivity during the pre-symptomatic period. It does not mean that there is viremia at that point. If a symptomless donor tests positive for SARS-CoV-2 on day 14, but this is not evidence that there is SARS-CoV-2 in the product. Actually, it is evidence that the pre-symptomatic infection on day 1 is effectively excluded. Therefore, discarding a donation for failed quarantine is detrimental to the patient because they lose their first choice donor, and also detrimental to the donor because their exposure to GCSF, apheresis, and unnecessary COVID-19 community risk is wasted. And of course, local law and regulations will always take precedence. Next slide, please. The evidence on which we base ourselves is, of course, the scientific evidence as published so far, which shows that there are receptors in airways and the virus is predominantly in the lungs. There is very low levels of viremia only detected in some symptomatic patients between 1 and 15%. And so far, there is no evidence of transmission through blood or hematopoietic stem cells of SARS-CoV-2, nor for other corona or non-latent respiratory viruses. So we feel that quarantining the product increases the risk of wasting a good donation and the commitment of our brave donors without significantly increasing the safety for recipients. Thank you.
Thanks, Miriam. I'm going to speak a little bit about our UK donors and our experience over the last few weeks in providing donors for transplant. As a donor registry, our main aim is to manage the safety and health of our donors, and that's our priority. And so in response to the COVID-19, we've put a number of steps in place to support those donors. So we've provided training and frequently asked questions guides for our staff to provide donors with and patients and staff members with the answers that they need. We've prepared donor information to provide all donors with facts and also with advice to avoid transmission of COVID-19 or exposure to COVID-19. And to provide reassurance as far as possible. We've revised our health history questionnaire and our testing policy to ensure that our donors are as safe as possible when they move forward to donate. We are deferring donors who are classed in the UK as part of an at-risk category. We're working with our collection centres to ensure that the collection centres are as safe as possible for donors. And we're adapting and adjusting our travel and accommodation itineraries in line with the challenges that we're facing in the UK. And since 2 weeks ago, we have removed the requirement from donors for a blood sample at verification typing stage, though we are looking at alternates to this at the moment. All of these activities are to ensure that our donors are well supported and that we can provide as much reassurance as possible so that they're still available for patients when they're needed. Next slide, please. Despite all the reassurance, it's understandable that we're still seeing some reluctance at the verification typing stage. And I've just included some of the examples of the responses that we've got over the last few weeks. Donors who have family members self-isolating, donors who have family members who are key workers, and donors who are just generally unsure about travelling at the moment. In saying all this, our usual donor availability at verification typing stage is about 70%. And during February and March, our donor availability was still at more than 60%. So we're confident that our donors are getting the reassurance that they need to continue. Next slide, please. We've seen, like all registries and transplant centres, many challenges at the workup stage. And as well as the transport challenges, we've seen a slight increase in deferrals due to these at-risk conditions, which includes conditions such as asthma, which would usually not cause a problem. We have found a small number of donors testing positive for COVID-19. We have had a small number of donors who feel that despite having gone through verification typing, that they feel that they can't go ahead with donation at this time. And then we have some donors who are based in remote areas of the UK where it's difficult for us to arrange travel for them to a collection centre at the moment. Next slide, please. But despite these challenges, for Anthony Nolan, as was reflected in other numbers from other registries, for Anthony Nolan, February and March 2020 were our busiest 2 months for provisions ever. We facilitated more than 300 collections over the 2 months, imports into the UK, exports to international registries, and domestic provision. We imported cells from 13 countries and were able to export cells to 16 countries. And we've also been identifying backup donors or cord units for every UK patient. So to support our UK transplant centres, we've been ensuring we have a backup in place. This has been possible only because we still have donors who are willing to be available if needed. We're working with each donor to treat them as an individual and to support their specific needs and concerns that they have at this time. I think the main message is that while we will see a reduction in April, this will mainly be linked to patient factors and the challenges in supporting transplant rather than to donor factors. We're still facilitating collections every day, and as an unrelated donor registry, we're still open for business. I'm now going to hand over to Gabby Rowell from DKMS.
Thank you, Anne. I'm going to talk most of the presentation about the transport. As you can imagine, that's a big concern for many of us, but also then about health and availability check and some difficulties in the workup in these times. So how do we ensure the transports in times of COVID-19? Europe, even though the borders are closed, transport within Europe are still possible in most of the cases, as there are exemptions on many borders for the couriers and medical products. Where there is a problem with crossing border, there are other creative things like the handover at the border from Poland to Germany. It's in Słubice or Frankfurt Oder. So a courier brings the product from Poland to the border, and there another courier picks it up, or the other way around. Anthony Nolan, very early stage, created a hub at the Heathrow Airport in London, so couriers do not have to leave the airport. Someone will bring the product in to the Heathrow Airport, and the courier is taking that back to the transplant center. The same in Spain and Italy, where there are hubs in some airports, so the couriers can hand over the products there. WMDA then got EU legislation for transport of the cells cross borders, and this can be handed on to the courier so that they may not have problems in delivering the products. But this is only then for Europe, which is a big part already, but still we all have also exports to other countries. And together with our courier companies, Time Matter, with NMDP, currently DKMS and WMDA, we have developed a possible cargo solution where fresh products can be shipped in the cockpit of the aircraft. And that goes from Frankfurt to the US. And we have started that from today on, that products are being brought to Frankfurt Airport and then going with the Lufthansa cargo to Chicago, where NMDP makes sure that the product will be distributed to the transplant centers in the US. Before we have started today, we did some test shipment of blood samples, and both test shipments have been successfully performed. So we are very, very sure that this is a procedure which is absolutely safe for the product, and that the product reaches the transplant centers. Of course, if we are now successful with the US, which is a big part, then we could also discuss on other destinations, or even with other airlines. Last week we have done one shipment with LATAM from Germany to Chile, which worked out very well. But we always need to have someone in the country where the product is going, who takes care about customs clearance, which is different than if you ship fresh products with a hand courier. Next, no. But it might be possible for other countries, but not for all. For example, for very long distance flights to Australia, that might not be possible because there we have a change in flights and even airlines, which makes it much more complicated. So for those countries, we decided to use cryopreserved shipments, like the cord blood shipments. So cryopreservation is recommended in these days anyway. So that could be the last option if there are no passenger flights are available, or couriers do not get a waiver to enter the country. Many registries do have experience with cord blood shipments, so it should be not a big problem. Only the donor center and collection center need to be prepared that they can cryopreserve the products in the collection center. And I think many cord blood banks may be able to support the registries if they don't have the experience how to ship or how to receive a product. Of course, also TCs need to accept that they receive a product which is cryopreserved in a different country. Not all of the collection centers may have JC or FACT accreditation, but usually they do the cryopreservation for own products or for the hospital, so that should then be accepted by the transplant centers. And this is the slide I got from Bronman. So we see here that the almost 100% of the products from mid-March on are cryopreserved, and we have now even requests for cryopreservation for mid of May, when the workup has already started. As Anne has already said, there sometimes are issues with donors going to blood donation for confirmatory typing or verification typing. So more and more registries and donor centers are facing problem with blood draws because people are forced to not leave the house and there's shelters in place. Donors are afraid to go to a blood drawing site, or even doctors and laboratories refuse to draw blood. And as most of the donors nowadays are high resolution typed, we have started to implement a health and availability check, as many other registries have done now. What we do in the health and availability check, we give the donor a detailed information session over the phone. We do a health history questionnaire with additional questions for screening for COVID-19. We check availability and product preference. And of course, we report all these results back to the transplant centers and registries. And then the transplant center can start work up whenever needed. And then the confirmatory typing or verification typing samples are drawn at the medical examination and shipped to the transplant center for the testing. As that, I also want to speak a little bit about issues we have with the workups. Mostly that is for bone marrow. Bone marrow collection capacity may collapse due to either a staff reason, need for ICU beds, or availability of ventilators at short notice. Therefore, in the current situation, bone marrow products should be reserved for those patients where PBC is no option, especially small children and recipients with non-malignant conditions. So we strongly recommend to switch any bone marrow request to PBC where medically feasible. We still will accept bone marrow requests and do everything possible to continue, but we cannot not longer ensure that we will be able to collect this product to the same extent as we could for peripheral blood stem cells. And that was my last slide. I hand over to Christian now.
Well, thank you so much. I will conclude reviewing the situation with access to CAR T cells, immune effector cell therapies. CAR T cells are autologous in nature, so we don't have to deal with the donor management. But access to CAR T cells and the manufacturing process heavily rely on long-distance transportation, so we can face similar issues as the ones that were just discussed in the 4 previous presentations. Let me consider 2 aspects. One is patient management, and the other one is the supply chain. Regarding patient management, at least for the 2 approved products, they are indicated for relapsed or refractory aggressive hematological malignancies. And this is a quite different situation than autologous or allogeneic transplantation that in many instances are indicated as consolidation therapy or for the treatment of chronic diseases. So that may leave some opportunity for patient deferral. This is much more difficult for patients with either acute lymphoblastic leukemia or aggressive B-cell non-Hodgkin's lymphoma, in which even in normal life, we know a key issue is disease control during the turnaround time for medicinal product manufacturing. and whether bridging chemotherapy is indicated or feasible if the manufacturing of the product has to be delayed further, needs to be discussed on a case-by-case basis. As already mentioned, there are 2 approved products, but there are also many more CAR T cells that are investigational, evaluated in the context of clinical trials. And since clinical trials are in need of a lot of human resource and travel to the investigator sites, most of them have been placed on hold for new inclusion. So again, check with the sponsor of ongoing clinical trials. But in most cases, the sponsors have closed the clinical trials to inclusion. For the patients who are already included, monitoring is limited as much as possible, while of course maintaining the safety of the patient. Feasibility of treatment with CAR T cells require a number of conditions. Patients must be free of SARS-CoV-2 infection as free of any other type of infection. So depending on your regional, local recommendation, evaluation may take use of a combination of clinical evaluation and testing. Patient needs to access the collection and apheresis facility. As previously mentioned, many apheresis facilities are still up and running, but it will be important to monitor in the future whether we can still acquire the necessary disposables and maintain the equipment. Of course, patient needs to access the hematology wards. Many hematology wards have tried to separate COVID-19 positive and COVID-19 negative patients. A critical issue is whether or not patients can access the ICU in case they develop high-grade side effects such as cytokine release syndrome, neurotoxicity, or others. And many patients need to access many other hospital facilities, including MRI as an example. Supply chain on the next slide. So far, the supply chains from the different pharma companies, the different manufacturers, appear to be minimally disrupted. You need to closely monitor the information released by manufacturers as the situation may rapidly evolve. The only stable information in today's world is that everything is unstable. Tight communication between hospitals and manufacturers is key at all steps of the manufacturing process, but there you can take advantage of the IT systems that have been deployed by manufacturers. And the key rule is, as usual, wait for the reception of the released medicinal product at the hospital pharmacy before starting the lympho-depleting regimen. And finally, check availability of all the needed resources for the supply chain, whether or not the collection facility will be able to collect autologous blood mononuclear cells. I already stressed that there is today no shortage of equipment or disposables, but that may change in the future. One of the major manufacturers of disposables for apheresis machines recently signaled that one of his factories closed in relation to the COVID-19 pandemic, so that may affect your ability to pursue this activity in the future. Check whether the collection facility is located at the same hospital as the one where you work, or is provided by another hospital or blood bank, a third party. Shipment by the to the central manufacturing organization is usually subcontracted by manufacturer. Again, so far we've not get signals that it could be interrupted, but the couriers face the same problems as in the field of unrelated donor transplantation. However, with the conditions that the cells when they are frozen, may travel from one side to another without a courier. So use cargo flights, take advantage of cargo flights. Manufacturing capacities, many, if not most of them, are based in the USA. The USA are entering the pandemics after Europe. So far there has been no major disturbance, but again, check that it does not change in the future if the USA are affected even worse than they are today. A positive sign is that new facilities are opening or should be opening shortly in Europe, improving the capacity of manufacturers to produce CAR T cells. And shipment back to the hospital, again, is subcontracted by the manufacturer. So very tight communication to check that the product will be able to reach the place where it should be administered to the patient. Thank you.
Thank you, everyone, for turn on my webcam again. Thank you, everyone, for these presentations. Very clear. We already have one question. If there are more questions, I ask you all, please use the Q&A and send your questions. I now ask all panelists to please unmute and also turn on your camera. And for the first question, the question is, PCs increasingly request more than one donor at a time for workup due to all current uncertainties. And this further increases the workload for registries and donor centers and CCs. And it frustrates donors. So what is the recommendation of WMBA and EBMT on this? And maybe Bronwyn, would you answer this on behalf of WMBA?
Oh, sure, I can start. And then I think probably Gabi and Anne and Nina will also have some recommendations on this. Certainly the recommendations from the clinical point of view, all patients who are planned for transplant is to have a backup donor available. Of course, this doesn't have to be an unrelated donor. It can be a cord blood unit, it can be a family member or a haplo donor. But the requirement to be able to go ahead is currently what is being recommended. I do realize that this will increase the workload in registries. I also think what I've heard from registries is that donors themselves are very willing to do this in these times. Donors are very eager to be able to help in any way that they can. And really, it has to be a balance between the risk to the patient and the risk to the donor. I'll hand that over to any of the others on the panel who'd like to comment.
Yeah, I would like to comment. I think from my point of view, I understand the situation that transplant centers want to request more than one donor. Now, I mean, we have always received these kinds of requests in normal times. I really don't understand that always, but in this time I understand. I just think we should be, it should be very clear to the donor center that there are other donors which are in workup at the same time. So, and it should be also clear which one would be the preferred donor and which one would be then backup donor, so that we can inform the donors. And do not, get wrong expectations from the donor and disappointing them. But otherwise, I think at the moment, for me, it is a procedure which I can agree to. We just have to be also then a little bit, it's difficult at the moment if we have to shift bone marrow to PBC and the capacity is low anyway, if we then have a lot of double and triple workups and the slots are taken. On the other hand side, I think with the cryopreservation recommendation, we are not so fixed on a specific date and can maybe stretch that a little bit instead of having fresh products where it need to be timed with the conditioning of the patient. So I think it's manageable, but we need to have a clear information from the transplant centers.
I would agree with what Gabby has just said, and just to add that, to reiterate the importance of information to provide to the donor, because a lot of the information we're providing at the moment and the support we're providing to donors is about building their trust, and the more information we can give them about what is expected of them during this time, the better. So we're happy to support a number of workups for a patient, and having backup donors, we're very supportive of that, and our focus will always be on doing the best that we can for the patient, but with making sure that the donor is well informed and that they can trust us as we bring them through this process.
Yep.
Thank you. Does anybody else want to comment on that, or can I go to the next question? I will go to the next question. I think this one is for you, Gabby. Do cryopreserved stem cells being transported in an LN2 dry shipper need X-ray exemption?
Actually, I don't know. I'm not a cord blood expert, and I have no experience with the shipment of cells in a cryopreserved, in a dry shipper. So I'm sorry, I may not be able to answer that now, but I can ask my colleagues from the cord blood bank what they do usually with the cord blood shipment, or maybe someone else from the audience knows and can tell.
Yes, and otherwise I will be sure to add it to the Q&A, and it will be available afterwards. Nobody can answer this question at the time. We're getting a third question. Do we have any data about the risk of GSF for donor who became COVID positive by increasing the inflammation immune response against COVID?
I can comment on that. I am from the Serum Spear Committee, and we have not received any adverse events of donors receiving GCSF during COVID-19. But please, if there are any, do report them to WMDA.
Yeah, as Lydia says, there is, sorry, Miriam, it says we don't have any reports, and I haven't seen any data about the risk of GCSF. However, we must assume that this is at least a theoretical risk. We do know that GCSF can cause flares of autoimmune conditions. We know that patients donors who receive GCSF in the setting of an EBV or other infection have an increased risk of adverse events such as splenic rupture. And so while we have no hard data that I've seen, this is something that we need to bear in mind.
Yeah, very much so. That's why we urge registries to focus on donor safety and to stop the procedure if there is any concern for donor safety.
If you think of the old literature on cytokines and hematopoietic growth factors in the 80s and 90s, pulmonary toxicity has mostly been reported with GM-CSF, not very much with GCSF. So probably the risk is quite theoretical, but I would support that we need to collect data and survey and report. So if anyone faces such an event, please report to the appropriate regulatory body and professional associations.
Yes, thank you for pointing that out, Christian. I think that's right. And Miriam mentioned previously the WMDA reporting system. It's called the SPEAR, which is both an adverse events and reactions registry for things that occur to the patient or to the donor. It includes reports of near misses. And so this is also something that can be reported. It's an electronic reporting mechanism, which you can find on the WMDA website. Usually it's the registries who report to us. And so if you are in a transplant center, you can speak to your national registry about how to go about reporting something. It's predominantly for unrelated donors. However, people can report related donor events or reactions too. And also the EBMT has a mechanism to collect in the PROMIS and then macro system these type of events, although the EBMT is not curated in real time, which the WMBA.
Yes, thank you for pointing that out, Bron. And the big advantage of the WMDA system that it's looked at by experts on a weekly basis, so that if there's anything that it's worth reporting back to the community, will be picked up quickly.
Yeah, thank you. We're getting a reply about the dry shippers carrying the stem cells, and they are exempt of X-ray, is what I'm getting here as an answer from one of our participants. There's another slide also about cargo flights. Do you plan cargo flights to other destinations than US and Germany? Gabby, I think you already mentioned that this is the case, right?
Yeah. So, yes, we have done one last week from Germany to Chile. I am having a call later today with the registry in Argentina. So wherever we have cargo flights which is going directly without changing planes or even airlines, it should be a possibility, but we need to talk to the airlines, and we need to have a specific process in the country where the plane leaves with the customs clearance, and the possibility to hand over the product directly to the pilots. And we need to have in the receiving country supports from the registry to go there to the airport and pick up the product. Otherwise, it could happen that it's very long in the customs, and with themselves that is not acceptable. So if there are registries who are interested to support, they can let us know, and we will then look on the options, which airlines are available, how committed are the airlines, etc. So, but yes, it is possible.
Thank you. It's good to know. You're working together with several courier companies, right, Gabby?
Yeah. So with Time Matters is doing it here in Germany, in Frankfurt, and they are directly connected. They're basically they're with the Lufthansa. So they're within the Lufthansa company. So there it was the easiest to start with, but I think also if we are promoting that and other airlines see the success, maybe we get even more airlines who are willing to help us.
Okay, good, thank you. We don't have any other questions at this time. So I don't know whether there are any other comments you would like to give for our viewers, or if we can round up. And if nobody has any comments, then I would like to thank everybody for attending today's webinar. And especially since we are all facing this COVID situation, I thank you for your attendance. I hope you stay safe, everyone, and please be sure to check our website for next webinars we will be hosting to keep you updated in this time. Thank you very much.
Thank you.
Thank you to all our presenters. Wonderful. Yeah, thank you for your collaboration. Okay.
Bye.
Bye-bye.
Bye.
Bye.